So thank you so much, everybody, for joining us. This session is called the Institute for Healthcare Improvement Pursuing Equity Initiative. And this is a great follow-up to our plenary session that we just had with Jeff Trask. So I hope you got to enjoy Jeff's presentation just a little bit ago. And now I am pleased to introduce you to Julie Darnell. Julie is our conference chair this year, and she's also going to be moderating today's conversation. So if you are just tuning in, we've been having a great morning. We're learning a ton, but now I'm going to turn things over to Julie to lead the conversation.
Hi, everyone. I'm very excited to introduce the stars of this morning's show. We have executive directors from 3 Illinois clinics. First, we have Mike Romanoli from Community Healthcare Clinic, Suzanne Hoban from Family Health Partnership Clinic, and Sean Wes Marconi from the Will-Grundy Medical Clinic. What all of these clinics have in common is that they competed for and were selected to receive 18 months of intensive coaching valued at $30,000 each from the Institute for Healthcare Improvement, which is arguably the nation's premier organization devoted to quality improvement. They have joined IHI's Pursuing Health Equity Learning and Action Network, which involves other health systems and providers across the country. This initiative began in 2020. It runs through March of 2022, so they're about 6 months in, about a third of the way through. So we thought this was a great opportunity for them to share their learnings to date. As Lara Starr had mentioned, I think we're really teed up nicely following Dr. Zike's remarks that, you know, when they're looking to award funding for projects, they have an equity checklist. They're looking for organizations that are addressing equity. And we heard from Dr. Trask that when, you know, we just need to sort of think about equity as part of our DNA. So we'll hear from 3 very different clinics on their own journey. And I think that they're going to be very inspiring to you to both start or continue equity efforts in your own clinics. So where we'd like to start is for you know, one of the clinics that's knee deep into this experience. We'll ask Mike to sort of tell us, what is this initiative about? Can you set the stage for the discussion?
Sure, thank you, Julie. So I'm Mike Romanoli with the Community Healthcare Clinic in Normal. And as Julie said, we're about 6 months into this program, and I think I'm finally able to tell people what it is. So timing is good. So the kind of as an overarching goal here, so the Pursuing Equity Initiative is about eliminating health disparities across basically all systems. So you're taking any category that you can divide people in, primarily race and ethnicity, but also anything you can imagine, you know, sexual orientation, disabilities, education level, and making sure that any category that you can put someone in gets equitable treatment. You know, and early on we learned that equality and equity are not the same thing. Equality is doing the same thing for everybody. Equity is making sure that everybody has the tools that they need to succeed and meet their unique needs. So, which, you know, initially, you know, it's kind of funny, we started this and I thought, you know, we see a lot of, you know, different races and ethnicities here. So maybe we don't even need to do this, you know, but within doing it, it's definitely showed that, you know, implicit bias is a thing, 100%. And for us, it's, you know, helps you, it's decreasing racism, working within other community organizations in town, you know, strengthening how we take care of our own patients. So it's multifaceted, but really the overarching, like I said, overarching goal is decreasing any inequities within, you know, our patient populations here.
Thank you, Mike. It's really helpful to sort of get the conversation going. The first question we have for each of the panelists is, why did you pursue this initiative? We'd like to hear from Suzanne first, and then ask Sean to go second, and then Mike will wrap up this question. So why? Jeff reminded us that we need to ask the question why.
And we need to keep continuing to ask the question why, even after we get to those answers. So we really decided to participate in this for a couple reasons. First of all, frankly, it was a really good opportunity to play in the same sandbox as some pretty significant healthcare players in the country. In our cohort is, I think, Women in Brigham's Hospital this year. We have some Kaiser Permanente people in this. And to be able to learn and listen and discuss some of these issues with much larger healthcare organizations, we thought would be fabulous. It's been really interesting, and I'll kind of save some of my other remarks for a little bit later when we go in there. But the other piece was that we joined because our board had been looking at this issue really from a systemic and board perspective for the last few years. Our population in our clinic is about 65% Latinx. The number of Latinx people on our board of directors is absolutely zero. And that right there is a discrepancy and a disparity and an inequity that the people that we're serving and the community that we're serving is not even represented on the board that is making the decisions for this. So this has been an ongoing board decision, and we felt this was a way to really further that discussion and look a little bit deeper with some good guidance.
Thank you, Suzanne. Sean? Oh, yep.
I got it. Thank you. So our reason for joining this initiative is, it's similar to the other panelists. This definitely was and is a fantastic opportunity to collaborate with others across the country. But then also looking at our clinic and why we exist. We are here because of a lack of equity in healthcare. The fact that there needs to be a free clinic, the fact that we don't have everyone covered in this country just demonstrates that there are challenges to equity and access that have to be addressed. So we thought that it just seemed very fitting that the clinic take part in this initiative, and also to have that opportunity to collaborate, and then also to have that opportunity to better serve the community. Being a part of this initiative will better equip the clinic to meet the needs of this population that we're serving, a population that is often marginalized and underserved. The fact that many of our patients, they have to live in the shadows, even though they are in the immigration process and they are actively pursuing citizenship status, many of them, they still don't have access to the full systems and support of the nation that they reside in. So just the fact that this is the population that we're serving, for me, it was important for the clinic to be a part of this initiative, so to learn and to grow and to be able to better serve our patients and the overall community.
Thank you, Sean. Mike?
Sure. So for us, timing was interesting. Before these awards were announced, we had finished our PCMH certification 2 weeks prior. And we're actually looking to just take a break for a while, but here we are. So for us, it came down to, taking better care of our patient population. We are 86% non-white is our patient base. So the marginalized populations, that's our people. And at the time, then still, we were seeing an influx of patients from Africa, primarily Congo, who we were not taking good care of. Translation was a huge problem for us, and some startling blood pressure, diabetes numbers that we really needed to get a handle of. So it kind of all came together at the right time for us. And it was a chance to work with organizations that we would never collaborate with, Cedars-Sinai, there's a hospital in New Zealand and Toronto. And so taking care of our patients, of course, was one piece of it, but then also to collaborate with these other huge places, kind of see how giant systems work was another very attractive piece of this.
Thank you. Now I'd like to turn our attention to a new question and ask each of the panelists respond to a question: what parts have been most helpful? And here I'm going to ask Mike to go first. And Sean.
Sure. So a couple different things. So the first thing that was helpful for us, it was intimidating initially to be, you go into a breakout session and here's my little clinic, with my 12 people and sharing what we're doing. But it really does help to be able to get ideas from places that have no idea what you are. I have no idea what your population is, your community, what your resources look like. And sometimes, you get some ideas that are like, well, that's not even feasible here. But then to be able to speak to people that do it differently and are in different parts of the country, it really is helpful to get ideas from way outside your bubble. And then, Dorian is our consultant. He's been incredibly helpful because Lee and I, who's my operations manager and huge in this project with me, we want to, we'll fix the world tomorrow. So, but to have Dorian be like, now let's just think about this for a minute, has also been really, really helpful. And it's coming later, but the capsule exercise was also super helpful. I don't want to spoil that yet.
Thanks, Mike. Now everybody will be waiting in anticipation. Suzanne.
I think twofold. I echo pretty much everything what Mike said. I think the other thing was really helpful for this is the introduction to free and charitable clinics to these other organizations who literally have no idea that we exist, who we are, and what the heck that we're doing. I think that for our sector, it is critical for us to have a seat at these tables where we may initially feel intimidated, but as you may hear later, actually we may be doing things right. And we may have an easier time affecting change than some of these other larger, more bureaucratic, and gosh, a lot more well-funded organizations than us. But that's been helpful, as has the idea and the impetus to start some of these conversations at a staff level. This is not just something you can bring up in the lunchroom, eating your bologna sandwich. Do you think you've got implicit bias? It just doesn't flow like that. So really being targeted and having a guided discussion through this, I think has helped start some really interesting conversations with some very interesting results.
Thank you, Suzanne, for reminding us the nimble and innovativeness of our sector and the ability to respond. Sean, for you, what's been most helpful?
So what has been most helpful for me, it's actually two things. So number one, working with the data consultant, Dorian, really helping us to drill down on our data and understanding what it means and using that data to affect change, to improve our services. I have to tell you, and I've said this in other meetings, I thought because we are an organization that is minority female led, exactly, that's the biggest piece, it's female led. I thought that we had all the answers and we're doing a pretty good job, but then looking at our data and working with Dorian, I saw that there are definitely some opportunities for improvement. There are some areas that we miss, and there are some blind spots that we have. In particular, when we start talking about our projects, we've decided to change our project and focus on vaccine access. And, we surveyed our patients and it was really eye-opening. And for us, on the one hand, we want to say that, and I know I might as well say me in particular, I want to believe that educating our patients, that's a county and state function, but not completely. I mean, they are on our panel, they are our patients, and if they don't understand and if they are hesitant to take the vaccine, then that's something that we have to take responsibility for. In fact, there was just a study, and then there's so many studies now saying, well, how do you get people to take the vaccine? And there was one study that said if a person's medical provider strongly recommends it, they will take it. You know, like 80% of the time they will take it. And I thought, oh wow. So if our patients are hesitant, I can't say the county's not doing a good job. I can't say the state or the federal government. I'm responsible. We are responsible for those patients. So that's number one. Number two, it's been very helpful because I've been involved in a lot of conversations that I have been able to take back to the county, because I'm working on the county level and the state level in regards to vaccine access and vaccine outreach. And we have a bunch of initiatives right now in Will County because we are really struggling in Will County. And I was recently at a Board of Health meeting for Will County, and I took a snippet of a conversation that I heard in one of these meetings to try to teach the Board of Health, and also to teach the CEO of the of Will County's health department, to try to impart some wisdom about equity to her. And it was a conversation from a clinic in Tennessee. And so I was trying to get her to see those parallels and how things that we do as healthcare providers, how we can turn people into second-class citizens, and it's not malicious, and it's not even deliberate. We're not even trying to do it. It just happens, and that's why we have to be mindful. So, and I was so happy that I didn't have to use an example from my clinic or any, you know, it wasn't like that message was coming from me with a finger saying, don't you do that. It was saying, listen to this story from this little clinic in Tennessee. And so that's been wonderful. And I got lots of those that I can, you know, lots of stories to tell because of, you know, being a part of this initiative.
Thank you, Sean, and showing how you're using knowledge that you're learning and sharing it with others. And of course, as a researcher, hearing how the person who you like the most as a data person warms my heart. So now thinking about what parts of this experience have been most eye-opening or even difficult. And here I'd like to ask Sean to go first, and Suzanne in the second seat.
So I'm sorry.
Go ahead, Sean.
So the difficulty for us has been just managing it all and really getting all of the value out of being a part of this initiative. Because we joined this initiative, what actually we wrote wrote the application to be a part of the initiative, it was probably maybe a few weeks after the onset of the pandemic, but you know, the country had not felt the full brunt of the pandemic, and we had no idea how the pandemic would change our operations and actually affect us continuously on a day-to-day basis. And I wanted to get, and I still want to get the very most out of this initiative. However, it is difficult to manage. There is a very, very significant time commitment, and that it's just been really hard for us managing that. And then also, as far as what's eye-opening, it's very refreshing. You know, the fact that we don't have all the answers, and that I think that at least, you know, from my little corner of the world as a free and charitable clinic, I often think that, you know, challenges to access and also understanding the underserved and what needs to be done. I think, well, of course, you know, we have all the answers here at the free clinic, but we really don't. And being a part of this initiative has provided so many learning opportunities. and so much really good information. And you know, coupled with that is the difficulty in managing it all, and actually being able to attend all the seminars. You know, it's kind of like drinking from a fire hose. You know, and it has been very difficult.
Yeah, I would have to echo Sean's. I think the most difficult thing for us has been managing it time-wise, and particularly since we started doing our vaccine clinics in mid-February, this has taken a complete backseat to everything because we are literally treading water right now, trying to keep up with the vaccine. And Sean did sort of allude to this as well, that it's been a little difficult because my clinical manager and I are spearheading this, Pat, and we have maybe 5 other people who are part of our team, but you get onto these calls and there are health organizations that have 25 people on these teams with job titles and heads of departments that I didn't even know existed and what they do. And here we're trying to do almost the exact same thing with a very, very small group of people. So the time has been challenging, and it does take up a lot of time, and it takes a lot of if you want to get something out of it, you got to put a lot into it. And at some point, you know, that's tough to pull out of the well. I think the other eye-opening thing, and what's been pretty interesting, is again, especially in the beginning, some of our team discussions and some of the, again, as we were forced as a clinic team to sit and kind of work through some of these questions and processes, really listening to and hearing from some pretty different and divergent perspectives on the issue of health equity, and going back to the issue of really what is health equity. We sort of came to this point thinking that we were all on the same page starting out with, but in the first few meetings, it was apparent that we weren't all on the same page, what this meant and where we all were and what we all believed was health equity. And so that, I think, was both eye-opening, and again, while difficult, I thought it helped me understand better that I just can't assume that everybody thinks and is at the same exact place as I am as we try to move forward. We really need to step back and look at a broader perspective to bring people together and understand where they are as well in this whole journey. We're all sort of on different paths on this spectrum. So that's been very interesting for me.
And Mike.
Sure. So for us, like I said, we're focusing on our French-speaking African population. So now that we've been addressing that, that group and getting much better communication in here, we have learned so much from those folks. I mean, so much. And then as far as the difficult part, so we are working with our local hospitals as well, and with primarily with basically what happens when a non-English speaking patient goes into the hospital. So we've done a lot of kind of, I don't want to say research, but just looking at, medical records from when our patients go in, and, it's patients that we know do not speak English, but somehow during an admission, they learn English. It's amazing how that happens. But so then, we go from that to, meeting with hospital leadership about, what happens, and how does this work? And there's been a lot of people, when we meet with them, they're like, well, that's that person's job, or, so it's, so with working with them has not been easy, because I really, really I'm not, morally safer rolling up to do like this big expose, on hospital translation services. It really is trying to help them take better care of people, because it's in the hospital, it's a safety issue. It's the first thing. People that if you don't understand, what's happening for a procedure, or it's midnight and the nurse is coming in to give you a medication. So Angie, who's the compliance officer for one of our local hospitals, she and I have become friends through this. I've made her life way more difficult because as she continues to look into it and make it better, it's just, it's kind of exposed a little bit like just, wow, we do a really, really bad job, with our non-English speaking patients. So it's been good to work with them. At the same time, it's just been like, man, guys, you are really bumbling, when it comes to this. And in Bloomington Normal, we're a very, very white community. And so up until this point, the community is very white. My clinic is not, but the hospitals are, that's who they're seeing. So it's really not been a priority because it's never had to be. So working with them has been a little disappointing is a strong word, but really, and like Suzanne said, not everybody, thinks the same way or is used to, seeing the patients that we do. So when you encounter someone that isn't into it, it's not easy.
Thank you. I think what comes across from all three panelists on this question is, while this is quite challenging to put into practice because of the time that it takes, that the rewards are great, the learnings that you have been able to glean even so far. So now let's turn our attention to what have been the initial takeaways or changes that are happening in your clinics. And I'd like to ask Suzanne to answer this question first, followed by Mike and then Sean.
Sure. So one of the things that this helped us do is part of this project is that each of the clinics or health organizations is supposed to have two specific projects that we work on. One of them is a clinical area of focus. The other one is, I'll call operational or organizational or structural, something that's not clinical. So as part of this, we settled pretty quickly on what our structural operational one was, and that was to help develop a patient advisory board, which is something that we've sort of talked about on and off for a number of years. And that's actually, I think, going to be really interesting because we view it as potentially a feeder system into, again, getting our board much more diverse and much more representative of the people that we serve. The other interesting takeaway was that we started looking at our clinical measures because we were trying to find where our inequities were in our clinical measures. So we started looking at flu vaccines, breast cancer screenings, hypertension, diabetes, all of that. And what was interesting is that within the clinical measures themselves, we were finding that we were actually doing really, really well, and there were no glaring inequities. So this amazing guy, Dorian, who everybody else has talked about, has helped us kind of refocus how we look at those clinical measures. And, even at one point suggested dialing down and drilling down into zip code or, township, and really kind of looking at, do health disparities exist in geographic ways, et cetera. We ended up focusing, like Sean did, on COVID vaccine because that's what we were in the heart of. And Dorian and IHI kept saying, don't try to invent a project, make a project out of what you're already doing. This is not supposed to be the hard homework. It's supposed to be something that is actually going to be practical and that you're going to continue long after this process. So those are a couple of our takeaways.
Thank you. Mike.
Sure. So for us, a couple different takeaways. First of all, for the people that are not aware, there's only 4 free clinics in this whole project, and 3 of them are here. So, so that's a little shout out to Illinois Free Clinics. We are the best, obviously. And then Julie had mentioned this earlier, but Julie coined the term nimble, God, years ago now. I mean, that was like pre-ACA, I think, was when you started using that. But in working with these giant systems, Cedars-Sinai has 13 people on this project. I have 12 staff total. So we were in a breakout with the director of the program from Cedars, and her biggest problem is, how do you do this over a large system? And she asked, like, how are you guys, going to start doing this work? And I just said, well, I'm going to leave the call and go out in the clinic and say, this is what we're doing now. And it really is that simple, so for a program that was designed for giant systems, free clinics, we are much more equipped to actually get to work, to get down to business, make changes really quickly. And, we are way out ahead of the large organizations. We're already testing our projects to see if they work in doing them. So that's really been cool to kind of flip the script a little bit on these big organizations and be able to kind of become the people that they're looking toward, for how to do this work. And then, internally change-wise, I went from 0 French translators pre-IHI, now I've got 9. So the way we've been able to, help that population has really been awesome.
Thank you. And Sean?
Yes, so our takeaways are very similar. Again, I have to reference our work with Dorian and how he has helped us to look at our data differently. We wanted to start with the big 2, diabetes and hypertension, and take a look at the outcomes. But the fact is, Will-Grundy, like most free clinics, we have pretty good outcomes with diabetes and hypertension, and most free clinics outperform the federally qualified healthcare centers because we're nimble. We have a competitive advantage in that we have a little bit more bandwidth when it comes to looking for free resources like medication and supplies. So we, never have a patient that doesn't have a meter, and we give them free strips, and and metformin is cheap and free for the most part. And then we've found a cheap supplier for insulin. And same thing with hypertension. We actually now have been giving out the blood pressure cuffs. So, some of our patients can monitor their blood pressure at home. And so, in looking at the data, we were, like Suzanne said, like her clinic had been advised to not try to create a project. So, just do what you had already been doing. And the thing is, we were in the thick of COVID, in the thick of our response to COVID. And so after looking at our data and then also realizing that the data it's not just by city, it's by zip code in the city, duh. It's also by township. I think we serve something like 28 townships. And then when you go into each city, like Joliet has a ton of zip codes, but then most of the townships and cities that we serve have more than one zip code. And so, there is a way to look at the data so that you drill down even more into the information and you can learn more from it. And then also, it's we've learned to have a better respect for it. I think that actually having time with the data consultant has helped us to better understand how we can use data to serve our patient population. And then also not just data, but then also how involved our patients are. And for us, our patients are not, unfortunately. They are a part of their care, absolutely, but they have not been a part of guiding how they receive their care. And that's unfortunate. And again, that points to how we can have a bias and think that because an organization may be minority led or female led or have a very diverse staff or a diverse board, you think that you're doing everything right, but everybody needs a checkup. and so our patients really have not. And at one point we had a program, we had our Zumba classes, and it grew to over 100 people, and this is pre-pandemic, and so we moved that to another community-based organization. And so, but we did have a lot of interaction with patients during that time, but that's been it. And so, what I realize is that we do need to include our patients, and we actually do a patient survey, but even our patient survey is so slanted because our patients are so grateful to see a doctor, and it's very focused on your doctor visit, and in the front desk, and we get like 98% satisfaction. I mean, very high. It's rare that we get anything less than a 4, and each category is rated from 1 to 5, 5 being the best. And so it's always all 5s or 4s and 5s. And so that should have been kind of telling there, because we're not, they're not telling us ways that we can improve. And so definitely we're not even giving them the opportunity to tell us how we can do better. And I think one of the ways, and this is one of the things that I changed maybe 2 years ago, but had been going on for years and years and years. And had we had better conversation with our patients, we would have caught this quicker. We were like this little clinic in Tennessee that I used the story about. And this clinic, if patients showed up without an interpreter, they would be sent home. And there was no recourse. There was no no safety net. Like, what happens if your interpreter is not helping or can't help that day? And so and that was happening here. It was a few years back, but that was happening at when we had our patient satisfaction survey. And so that patient satisfaction survey is probably 5 or 6 years old. And so maybe half the time we had a similar policy. And the patients didn't complain, but our providers complained because they would say, I'm not going to come all the way here and you're going to send somebody home. Like, and that was a policy that predated me. And, and I said, we got to do something about this. And so, and for the past few years, we have something in place. We have volunteer interpreters, and we've always had volunteer interpreters. And now we also use a very expensive platform for interpreting services. But, one of the big takeaways for me is, why didn't they complain? Did they feel like they weren't empowered, or they didn't have the place, that they couldn't? Because I know that would like burn me up if I am finding time to come to the doctor and I'm being told I can't be seen because we don't have volunteer interpreters, and staff are in other capacities and can't interpret. And I would think that's terrible service, because it is terrible service. So that lets me know that patients aren't involved enough, and our survey does not give them the opportunity to really speak about what they need.
Yeah, thank you, panelists. I appreciate, what I heard is the importance of data, but not taking that data without questioning whether or not you can trust the results that you get, and the importance of making systemic changes, like who's going to be on your board. Our panelists nicely sort of anticipated our next question: what are the areas of strategic and clinical focus? So I think a few of them have already answered this question. We've got about 10 minutes left in the session. I'd invite any of the panelists to make, maybe a little clearer which are your areas of strategic focus before we go to our last question on what advice you want to give, so we can leave room for questions. So just quickly, if maybe Mike, you could just make clear what are your areas of strategic and clinical focus, and then I'll have Sean and Suzanne tell us before we go to our last question.
Sure, thanks, Julie. So for us, the clinical focus area, which clinical focus is basically internal and strategic is kind of, external is how we took it. So our clinical area is addressing our French-speaking population. So that's what we're doing through adding all of our translation, because we did absolutely have disparities in their outcomes. And like Sean said, prior to this project, we were turning patients away if, because we didn't have a translator. So that was very, very easy, to pick that as our clinical area. And then the strategic focus kind of came about because of that. And that's where we're working with our hospitals to help them, better address their non-English speaking patients as well.
So I talked a little bit about our strategic focus, and that we really wanted to do this patient advisory board. Now, remember, we are at the beginning of this, so we have the concept down. We've identified like 3 people that we want to get on here, and we've talked to a couple other clinics, which were, again, helped facilitated that communication and connection through IHI and AmeriCares. But again, because of the COVID vaccine, we're just kind of at a standstill right now. So as soon as we take a breath, we hope to start rolling that out and implementing it as a way, like Sean said, to get better feedback from our patients, rather than just a survey. Let's dig a little deeper. And then the clinical focus, we've not completely refined exactly what we're looking at, but we really want to make sure that we're reaching our Latinx population on getting access to the vaccine. Because we can't contact all of our patients to find out if they've had it yet or not. We're going to have to really look in the next couple months with how many we've been able to vaccinate ourselves, how many we have data for, and compare that to our other populations within the clinic to see if, in fact, our real specific outreach and targets have been met. And we're coupling this actually with an initiative from Illinois Public Health Association on COVID response throughout the communities. And we are a lead agency in bringing in other marginalized groups to ensure that they have access to COVID resources, but especially the vaccine as well.
Great. And Sean, you want to tell us about your 2 strategic and clinical foci?
Yes, absolutely. So number 1, we're focused on vaccine equity in Will County, but then also within our patient population. And that came about, working with Dorian and looking at the data, and then also trying to work on a project that was something that we were in the thick of. And also our other strategic focus is looking for a patient to serve on our board. I think for us, the best way to give our patients access and information about what we're doing, and also to give them a voice on the direction of the care that we provide, is by adding them to our board.
Great, thank you. It's nice to see some of the similarities across how you're sort of thinking about ways to implement change. I'm going to ask each of the panelists to give a 1-sentence tip or piece of advice to others who either haven't yet started this journey or might have started but are looking for advice. Because I want to make sure that we've got at least a few minutes to open it up to the audience for their questions and their input. So 1-sentence piece of advice first from Sean.
Sure. So I would say evaluate the time commitment, make sure that everyone that's involved has an understanding of the time commitment, and also understand that these are systemic issues and it's a lot of work to affect change.
And Suzanne.
Make sure you know how your data is being input, because if you can't separate race and ethnicity and language and things, you're not going to really have an easy time figuring this out. And when we looked at our data, we saw race and ethnicity is everything from I'm Colombian, I am Mexican American, I am Mexican Chicagoan, We found all kinds of really interesting data in there. So make sure your data is clean and you're inputting it the right way before you start.
And Mike, you get the last word, one sentence.
Oh boy, this can be really uncomfortable work, but once you start doing it, it's not uncomfortable anymore. It's what you need to do.
Now we want to invite questions from the audience. And we actually have a question for the audience. What is your clinic doing right now to pursue health equity? So for those of you who have already embraced this arena in the spirit of sharing and learning from each other, I'd invite you to use the chat or the Q&A session so that we can save your responses. But this is also an opportunity for you in the 3 minutes that we have remaining to ask a question to our panelists. I'm not seeing any questions or responses yet in the Q&A, so that if you are the first to use this space, your question will definitely be answered live.
I have a quick question for the audience myself. Is anybody who's on the call currently using a patient advisory committee? And don't all talk at once.
I guess when you find that yes, then you'll know who to reach out to, Suzanne. Community health. So Emily has mentioned that they had a patient advisory panel. We have interest. So I think the nice thing about the IACC is that we can put clinics together who have the shared interest in understanding what might be some best practices around putting together a patient advisory council. It looks like there's quite a lot of interest in this concept. So thanks, Suzanne, for getting this idea across our network. Yeah, lots of interest in this. Well, I see that we just have 1 minute before our closing time. I want to make sure everybody has an opportunity to stretch. I want to thank everybody for joining us for today's panel discussion. And I'm going to skip over to that final slide and mention that we will have resources that we'll make available to you as extra supplementary material. The IHI has a wealth of free resources on their website, and they're the ones that are leading this effort for these 3 clinics. And additionally, if you'd like to reach out to any one of us, there's a sort of a complementary initiative underway that some of you might have heard of, the Roadmap to Health Equity, of which all of these 3 clinics are participants. And we're excited that we're able to leverage the learnings from their mentoring experiences to share around Roadmap to Health Equity. There's a pre-recorded session on that topic. So it's really great to see so much interest in pursuing equity in many different ways. So thank you all for your participation, and for the 3 panelists, I want to thank you for your time and expertise this morning. Laura, kick it back to you.